All right, let's continue our infectious diseases or antimicrobial lecture series for pharmacology 2. This will be week 2, lecture 1. I'm going to write that down so don't forget it. So we're still talking about cell wall inhibitors, specifically the beta-lactams. So we're going to jump into the monobactam, which there's only one, and that's acetrianum. So let me do a screen share and let's start looking at it. And we'll go from there. Minimize me. So the monobactam, so we talked about penicillin type antibiotics. We talked about cephalosporins. Now we're going to talk about monobactam. And your drug is going to be azactam or acetrianum. This comes in IV or IM. You can see its structure here. Now, one little caveat I want to tell you. Typically, when this initially came out, we didn't have a lot of resistant issues, but this was an anti-pseudomonal alternative if you had a cephalosporin allergy. So the problem is or a penicillin allergy, I should say, back when we weren't as savvy on penicillin allergies as we are now. The only problem is this structure. If you were to look at the structure of ceftazidime, which, if you remember, is a third-generation cephalosporin that we use for Pseudomonas, they're very similar. So while acetrianum is a viable option when there's a true penicillin or cephalosporin allergy or a carbapenem allergy, that statement is true unless you have an actual allergy to ceftazidime. Its functional group, if you were to look up, it would be very similar to what you see here coming off this beta-lactam ring. So first thing you need to know, the monobactam, acetrianum, limited activity. There's no gram-positive activity. We use this specifically for Pseudomonas aeruginosa. There's zero MRSA or enterococcal coverage. Those are both gram-positives. We just said there is no gram-positive activity. Works through cell wall disruption. Atypicals don't have a cell wall. There's no anaerobic coverage. So where do we use this? It's typically hospitalized patients, specifically requiring gram-negative organism coverage, more specifically those who we perceive or have documented Pseudomonas aeruginosa. But its big role when it came out is that it could be used for patients with penicillin allergies that require gram-negative coverage. But we know a lot more now about true penicillin allergies versus self-desensitization versus it's different R groups. It doesn't really matter. It does require dose adjustment. So where do we use this drug? I'm going to show you shortly. I'm going to pull up a different article, but use can be a concern, can be used with patients with a true beta-lactam allergy. Now, remember, unless the allergy is specifically ceftazidime, so keep that in mind. It's indicated for complicated and uncomplicated UTIs, including those kidney infections, pyelonephritis, febrile neutropenia, skin and soft tissue infection, certainly HAP and VAP, we have better options. Complicated intra-abdominal infections, if you give it in combination with metronidazole, remember it does not have any anaerobic activity. And then, of course, cystic fibrosis. This, though, is via inhalation to cut down on colony counts of Pseudomonas aeruginosa. Probably a nice addition because we were using colistin in some of those cases. So we have better alternatives, but this is what you can see with acetrianum. Now, where do we deploy today? It's not just for your common Pseudomonas infection. We do not do that we have better options, whether it be meropenem, imipenem, cefepime, maybe even ceftazidime. It's more similar to ceftazidime, but where we use it. So we talked about those Ambler classifications of resistance. So Ambler class A, those are going to be your extended spectrum beta-lactamases, your KPCs, your CREs, etc. Then Ambler class C, those chromosomal mediated or chromosomal induced resistance. And then, of course, your Ambler class Ds, which are your oxacillinases. Everything I just mentioned, Ambler class A, C, and D, cleaves the beta-lactam ring. Acetrianum is actually the only beta-lactam that maintains its sensitivity to Ambler class B. So those are your metallobeta-lactamases. There's 3 of them. There's New Delhi metallobeta-lactamase, there's the IMP, and there's the VIMS. Now, why can't we use it? Why does it show up resistance? Well, the problem is there's two other or three other mechanisms going on, specifically Ambler class A or Ambler class D, that renders it futile when it truly is a beta-lactamase producing Pseudomonas aeruginosa. So I want to show you what we do, what we figured. Used to, we would use a carbapenem that's anti-pseudomonal, and we would give another carbapenem such as ertapenem, which ertapenem we'll talk about does not cover Pseudomonas. It's the only one that doesn't. But what it does provide is we would use it as the beta-lactamase inhibitor. We would give it so it would block or bind up to the beta-lactamase because it had more affinity towards beta-lactamases, or the beta-lactamase had more affinity to the ertapenem, and then we would give meropenem after we gave it. So same concept, but let me show you real quick where we use it. We will give, so we talked about ceftazidime, a third generation cephalosporin, and adding the later generation beta-lactamase inhibitor, avibactam. I want you to look, this is Pseudomonas aeruginosa. This is Avicaz, is the brand name. This is a combination of ceftazidime and avibactam. This is an E-test strip. This is the bacterium growing. I believe it should be Pseudomonas. It is. It usually has a greenish tint to it, but it's not there. If you notice, there is no kill. If you look at the azetrianam, you're getting some kill, but you can see the minimum inhibitory concentration is roughly 64. That's well above the break point. So you're going to have therapeutic failure. But if we do ceftazidime avibactam with azetrianam, look what it does. It drops it down to a point where we can treat it. So we give the ceftazidime avibactam for the avibactam component because it will bind up Ambler class A beta-lactamases that are carbapenem resistant Enterobacterales type species or KPC type species. It also binds up the 4s and the 3s. That leaves azetrianam to do its thing for those. This would be an Ambler class 4 resistance. Avicaz is no good for that. Ceftazidime ava. We give it together because this will block Ambler class A, C, and D. Azetrianam is susceptible to Bs, and you can see how we do it. So we give them together. I think there's a disc dilution. You can see the same thing here. This is another example. I'm not sure what these isolates, you get my point. I don't think these are pseudomonal isolates here. I really don't. It would have a greenish, but yeah, there's a total of them there. There's several there, but it doesn't matter. You get the point. But that's where we would use it. And you can see you reestablish your susceptibility by making sure that you have a drug that covers Ambler class B, and then we give the avibactam. We don't care about the ceftazidime. That means nothing to us. We're just giving this for the avibactam. So you're probably asking the question, are they developing a drug that has azetrianam plus avibactam? And the answer would be yes, they are. They are. So let's keep on keeping on, but that gives you a role. That's where, if anyone wants to ask me, where do you see a clinical role for azetrianam? It's going to be multi-drug resistant or carbapenem resistant Pseudomonas aeruginosa. That's not due to, most of them in the States are due to poron channels or efflux pumps. This case, it's truly enzymatic. And so we would give azetrianam with the ceftazidime avibactam combo. The brand name is Avicaz, and specifically for Pseudomonas, but it would be applicable to all these as well in that combination. If you had Ambler class B, is a boy, resistance. Okay, the carbapenems now. When you hear the word carbapenem, this is the big dog of antibiotics, or bring in the big guns. No. The big gun is the antibiotic that works. Remember, there's not a difference in pathogenicity. The difference is in how many drugs that they're sensitive to versus resistant to. So many times you just have less options and you're stuck with the carbapenem. That does not make it better than cefazolin. It depends what you're treating when you deploy these antimicrobials to treat infections. So please appreciate that. Don't refer to this. Let's bring in the big guns. Well, define that. That's extremely subjective when you could say the drug that works is the big gun, and that might be nafcillin for MSSA in the blood or on a heart valve. It's all relative is what I'm saying now. We try to, if we can, mitigate the use of carbapenems. Maybe real quick, I can show you Well, let's just jump into the conversation first, and then I'll try to pull up something and just show it to you real quick. But you have several. You have imipenem cilastatin. I think this was the first one. Now, remember, if you remember me talking seizure opportunity, this is the one that gives you the biggest risk of having a seizure. And again, the only time I've seen it, it's just less than a handful of times. It was due to the fact that it wasn't renal dose adjusted, specifically in every patient that I've seen seize, I think 2 or 3, less than 5. The common denominator was they were on dialysis and they weren't renally dosed at all, and they seized. So now we do have another one. Gosh, the brand name escapes me, but it's imipenem cilastatin. The cilastatin is in there, so in the kidneys, imipenem's not broken down. That's the only reason cilastatin's there. But they came up with a new beta-lactamase called ribosomals. This allows it to be effective for carbapenem-resistant Enterobacterales, or KPCs, however you want to do it, that Ambler class A resistance. So again, you really wouldn't use this. This is going to be for specific utilization. Meropenem is the one that I always like to go with. I think it's the best of the carbapenems. Certainly, if you had CREs, this is where meropenem vaborbactam would come into play. We are seeing with ceftazidime avibactam for CRE and KPCs, there's the omega loop of one of the amino acid chains. We're starting to see some functional changes, and it's leading to resistance during therapy. When it comes to treating a patient with CRE on formulary, Vabomere is what Greg Perry likes, and that's the meropenem vaborbactam. But remember, you would only need this if you suspected or had documented CRE. Otherwise, you could just use meropenem for 10% of the cost. Now, Dorobax was on the market, but it was removed. There were some efficacy issues. Let's talk about Invance or ertapenem. It's a once daily. It has inherent resistance to several drugs, but I want you to think of 8, right? 8. So think of 8, like a monkey, gorilla 8. This is what it doesn't cover. Imipenem and meropenem cover Acinetobacter baumannii. That's the A. Imipenem and meropenem cover Pseudomonas aeruginosa. That's the P. Imipenem, way better than meropenem, covers Enterococcus. That's the E. Ertapenem does not cover any of these. And I need you to remember that and appreciate that. I've seen bug drug mismatches where the meropenem showed sensitive to an Acinetobacter. Oh, this is once daily versus 3 times daily. Let's just start ertapenem, assuming a carbapenem's a carbapenem. I need you to appreciate this, the deficiencies, and I have it right down there with ertapenem. 8, no Acinetobacter, no Pseudomonas, no Enterococcus. But these are very broad spectrum antibiotics. They don't necessarily induce their own resistance, but they're big time inducers of the resistance of other drugs, specifically cephalosporins, in the terms of Ambler class C induction. Gram positive and gram negatives are covered, but it does not cover MRSA. Your Enterococcal faecalis coverage is going to be more so with imipenem. I don't think for a deep-seated infection I would trust meropenem. I'm going to add ampicillin to this. It just depends. But yeah, and you don't get atypical coverage. Again, why? Because there's no cell wall for atypicals. But remember the difference with ertapenem and the others. Think of 8, no Acinetobacter, Pseudomonas, Enterococcus. Now, we talked about vaborbactam and relebactam already up here, but that just in essence expands the spectrum of activity to include CRE and KPCs. This is the only reason why you would do it. The other beta-lactamases don't. The other beta-lactamase with ceftazidime that does as well as the avibactam, but these bind those beta-lactamases that specifically destroy carbapenems and everything else. But we use this specifically for those CRE, KPC infections. Yes, it can be used for any hospitalized patient with those severe infections, but why would you want to add that other layer of cost when you could just do meropenem or just do imipenem cilastatin if you didn't have CRE or a KPC? So I hope that makes sense to you. They are renally dosed or dose adjusted. So if you have an underlying level of creatinine clearance decrease, GFR decrease, you want to do a dose reduction, but you need to appreciate within the first 24 hours, these drugs have very high therapeutic indexes, meaning the toxic dose is way up here, the therapeutic dose is way up here. If a patient comes in and they have distributive shock and they don't have chronic kidney disease that's at baseline, I'm going to please ask you dose it like you would a normal patient. You can come in 24 hours, and if the renal function does not improve once you increase perfusion of the patient for the distributive shock, then you can start making adjustments, but you can very, very easily end up underdosing a patient who may have an extremely severe infection, and you miss your opportunity for a clinical cure. So please, please, please keep that in mind. You're not going to hurt a patient given the full dose over 24 hours. And in most of your patients with shock or distributive type issues, once you have volume resuscitation, they're going to begin reperfusing those kidneys, and you're going to see your serum creatinine drop substantially and your creatinine clearance increase substantially to the point where it could be augmented. Now, I'm not going to go through augmented renal clearance, but I want you to take the time to look up augmented renal clearance and potential underdosing of drugs. You might think your creatinine clearance is 50 when it might be 150. It's usually going to be a younger patient. We do have risk stratifying strategies for those patients, but I need you to appreciate this, okay? So don't be quick to renal dose adjust. Imipenem's the one, if you do have a problem, that can potentially lead to some seizure activities, but meropenem will not, you're fine. Very, very high therapeutic indexes. Toxic dose, it takes a lot. You're not gonna overdose them. So word to the wise, and if you're gonna die from septic shock, many times it's going to be due to a gram-negative infection. Those that we see in the gram-positive, we usually don't see a shock episode if it's in the blood until we give it, and they're encoded for either a type 4 community acquired MRSA. That's what it's coded for, what they call a Pantene Valentine leukocyte. When you have lysis, you have a T cell response that's twice, 3, 4 times more than the normal response. It's what we refer to as toxic shock syndrome. So staphylococcal toxic shock syndrome. You can also get it with streptococcus if it's a streptococcus pyogenes that's coded for the M protein specifically. So I told you 2 specific pathogens that actually do have some increase in pathogenicity, but those are very rare. But that's when you typically have a problem with gram positives. But gram negatives, that's why I always say the septic patient, if you have an order for Vanco and you have an order for Zosyn, give your Zosyn first. Give your gram negative coverage first. And then we talked about ertapenem, the advantage being once daily. You do get anaerobic coverage, by the way. You do cover bacteroides with your carbapenems, so they can be used in monotherapy if you have a perf of your bowel or you need coverage, as does ertapenem. That makes ertapenem an advantageous drug in the outpatient world. So keep that in mind, but also if you're trying to cover Acinetobacter pseudomonas or Enterococcus, no bueno, not going to work for you. But the imipenem, you saw it combined with cilastatin. That's the only way you can get it. You give the cilastatin because the enzymes made in the kidney, specifically it's called a dihydropeptidase 1, and I actually have it right there, destroys it. So the cilastatin is binding that dihydropeptidase 1. The clinical pearls, the risk for seizures with this drug, this is a drug class, the risk is higher. Patients with existing CNS disease, meaning they have existing seizure disorders or renal insufficiency, and the primary suspect, again, is imipenem. I won't go into the details of that. But what are we going to use these for, the imipenem or meropenem? Not necessarily, I would not use it for this. If you had E. coli, even if it was an ESBL and Zosyn was good, or so, I would not use it for that. If it's an ESBL and it's Klebsiella, yes, that's based on the Marino trial. If you heard my previous lectures, you can appreciate the Marino trial. That was specifically for Enterobacterales, ESBL, bloodstream or deep-seated infections. We saw that if it's an ESBL, specifically, we saw increased mortality on patients who were on Zosyn versus meropenem. But when we did a subgroup analysis, it was pretty much specific for Kleb and not E. coli. You don't need it. We have other options for these. The Enterobacter species are the same. I'm probably going to go, because it's not inducible, I'm probably going to go with a carbapenem on Enterobacter, and then no doubt Pseudomonas. You do get your B-Frag coverage. I'm not using carbapenems for any of these for the most part. If I have Enterococcus faecalis or something and it's a deep-seated infection, I'm going to give ampicillin. Yes, 2 beta-lactams at the same time. That's what I'm going to do. So, and there's your ertapenem. Everything's the same, but notice Enterococcus is gone, Pseudomonas is gone, and if we had Acinetobacter on there, it would be gone. Okay, so the carbapenem combinations, we talked about it, the Weber-Mir. This is a combination of meropenem, Weber-Bactam. Gosh, the imipenem has the relebactam. I have forgot what that, but it's not Trojanta. While we're talking, I'll look it up on my phone because it's driving me crazy. So, imipenem. Anyway, I'll look it up and look it up. But what's the difference between this? Adding the later generation beta-lactamase inhibitor. Oh, Ricarbrio. Trojanta is cefiderocol. We'll talk about that later. But we add the vaborbactam to the existing carbapenem, meropenem. We add the relebactam. All this does is it takes these drugs, which would not be sensitive to carbapenem-resistant Enterobacteriaceae, KPCs, it now makes them sensitive to it. So it allows us to use it for carbapenem-resistant Enterobacteriaceae, or CRE. And you're thinking, well, doesn't Abicaz cover that? Remember, Abicaz is a combination of ceftazidime, a third-generation anti-pseudomonal cephalosporin, and avibactam. Yes, it does. But again, we were seeing on that omega loop protein, we were seeing some changes, some alterations that were actually leading to resistance during therapy with Abicaz. And I just don't want to take that risk. But I think personally, it's because it wasn't dosed appropriately. I've looked at some of those. Ryan Shields and some colleagues did studies and reports on that. They did a phenomenal job. If you could look up Ryan Shields, Abicaz, or search that, and you could pull his paper. Very, very informative. They wrote an excellent overview of that. But my thought is maybe when they had that, were they underdosing? Because remember, the pharmacodynamic target for a carbapenem is only 40 to 50% of the dosing interval. Now, if you have a lower MIC, you should be able to be above that 100% of the time. These are extended infusions, by the way. We give these over like 3 to 4 hours. So something to keep in mind. And with the cephalosporins, the pharmacodynamic target is being above the MIC for 60 to 70% of the dosing interval. But they're broad spectrum. Yeah, you could use them for ESBLs, but why would you? Just use plain meropenem or plain imipenem. And then Pseudomonas, you're multi-drug resistant. Yeah, as long as it's not carbapenem resistant. Adding vaborbactam and relebactam does not reestablish Pseudomonal sensitivities. If it's a poron channel or an efflux pump, a beta-lactamase inhibitor has nothing to do with an enzyme, and it's just not going to be effective. But no MRSA coverage. The enterococcal coverage, plus or minus. The imipenem, yes. The meropenem, I'm probably not going to do it. And then you don't get that atypical coverage. But where do we use these? Its indication for both of these is going to be complicated urinary tract infections, including pyelonephritis, and complicated intra-abdominal infections, but versus Zosyn. So it's going to show it's pretty much a wash for the most part. But we have separate studies. We repurpose these drugs specifically for CRE. That's what we use these for. Otherwise, we would just use meropenem, not the combo, or imipenem cilastatin, not the combo with relebactam. So glycopeptides, before we go to that, I'll show you some things right quick that may be beneficial to you. I won't dig around too long. If it takes too long to get there, I'll stop. If you see something that says URH, holler. There it is. But this will give you an idea. Now, I want you to appreciate if you go to, I might not be able to find it, and if I can't, that's okay. If I can't find it, I'm hoping I can find it. MRA, okay. Most of your hospitals are going to have restrictions on the utilization of carbapenems. This just gives you an idea. I'm just going to scroll through it. I'm not going to read it to you, but I'll keep it here so you can see it. But there's a couple of things: appropriate utilization of meropenem, what makes it appropriate. And these are based on literature. It's risk stratification, but I'm just going to and you can read through it. And I mentioned the Marino trial right there. But this gives you an idea of which patients would it would be beneficial for. So you can pause it and read through that. And then part 2, risk factors for Pseudomonas aeruginosa specifically, you can see the risk factors. Again, you can actually risk stratify your patient. And then part 3, meropenem specific mitigation strategies. And you can just pause this lecture if you want to read through them. I'm not going to test you on this. but I just wanted to let you see it and appreciate it. So we'll get back into our lecture. Okay, the glycopeptides. This is going to be a drug you see quite a bit, specifically vancomycin. We use vanco for the most part for methicillin-resistant Staph aureus infections, right? That's a big one we use. But there's some others. The iridovancin and dalbavancin, these are one and done glycopeptides, although we're doing more and more with these. I wish I had my paper I could pull up. We actually wrote one on treating various infections, a paper, osteomyelitis and endocarditis infections with multiple doses of dalbavancin. But these are one and dones. We're not going to get into a lot of discussion with this. But vancomycin, this is going to be your workhorse for MRSA infections. It comes in IV, so that's for systemic infections. Remember, the IV form does not get excreted through the gut. So you cannot give the IV for C. diff. If you're giving vancomycin for C. diff, it has to be the PO. But remember, the PO is not absorbed. So you could not use PO vancomycin for systemic infection. I've seen that mistake made for skin structure infection. So we'll talk about that. Telavancin, it's got a bad rap, but it never really picked up. But you mainly need to know when we talk about a glycopeptide, I want you to think vancomycin, then iridovancin and dalbavancin. I want you to think a long-acting version of vancomycin. Although there are some situations, if you have stasis growth with some of your gram-positive streptococcal species or your staphylococcal species, there's a dual mechanism of action with the iridovancin. I'm not going to go into it, but it can actually stop those non-dividing methicillin-resistant Staph aureus bugs or MSSA. So either way, what's the spectrum of activity? So gram-positive organisms only, including those that are resistant to resistant Staphylococcus, MRSA, MRSE, streptococcus species, specifically pneumococcus. That's why when we're rolling out meningitis, the number one cause is Streptococcus pneumoniae. And we will give vanco with it just in case we have ceftriaxone-resistant pneumococcus. We don't miss the opportunity to save the patient. So once we get our cultures back, we can drop it. And then sometimes enterococcus if it's not the VRE variety. And then, of course, I mentioned Clostridium difficile. This is where we use it orally. But no gram-negative coverage to speak of, and you're not going to cover bacteroides or atypicals. This is a gram-negative antibiotic. So what do we use it for? We use them for MRSA infections. That's what we use these for the most part. And if you have some unlikely resistant non-pneumococcal strep, like a group A, group B strep, you would have other alternatives. Certainly the vancomycin for Clostridium, this is the drug of choice. There's actually two drugs of choice for Clostridium difficile. One being fidaxomicin, brand name Difficid, or vancomycin. Where it comes in, or if you use vanco first and you have a failure, you give fidaxomicin. If you use fidaxomicin for several $1,000s first and that fails, then you try vancomycin. Metronidazole is no longer really included in that. But then again, iridovancin and dalbavancin, they only have FDA indications for skin and skin structure in infections. So I. But these drugs, or the big one with vanco, I should say, is the increased risk of nephrotoxicity. Now, that is concentration dependent. Depends on how high you maintain your trough levels. Greater than 15, you start increasing your propensity substantially for nephrotoxicity. And then telavancin also has but we don't see telavancin, but that's been associated with some increases in serum creatinine. But vanco for sure, the higher your dose, the higher your trough when you're monitoring it. That's one where you can increase your risk of nephrotoxicity. Not that it happens all the time, but it's not uncommon. We've all seen it in practice, and you will too. You just see it. But these are bactericidal. And again, it's working on that end thing. So here's how they get resistance. You can see here, you can have D-alanine, and then its resistant mechanism for a VAN-A is D-alanine. That's just that N amino acid changes to lactate. But again, our whole idea is to disrupt that peptidoglycan cell wall. Again, we're still talking cell wall antibiotics. We just left the beta-lactams behind. And remember, very thick cell walls for your gram positives. The thicker this wall gets, the more harder it is to penetrate. And a lot of that has to do with just one peptide side chain, one amino acid change on the peptide side chain, D-alanine to D-lactate. That's simple, and it's resistant. So the glycopeptides, very large structures, you can see here. What does that mean? No, they're not going to be absorbed orally. Now we give the vancomycin orally, but that's for a topical effect. There is no absorption. If there is, it's minuscule, and you have to have an inflammatory component to get it. There are some studies that you can have an appreciable level of 1. Never could use that therapeutically. Very large structures, so it's just you can't get into gram negatives. So recall the cell wall structures, and it's just not going to happen, and you're not going to get across the GI tract. Vancomycin, we talked about the narrow therapeutic index and the need. You have to monitor levels. We usually monitor this through trough levels or what we call the area under the curve. And I'll save that discussion for when you get out into practice, but just know when vancomycin is dosed, it does require drawing levels, whether it be the 2 levels within the same interval. So we can calculate the AUC. We want to keep that between 400 and 600. I prefer 400 to 500. We know when you get above 600, you increase your risk of nephrotoxicity. Well, an AUC of 600 is going to correlate to a trough greater than 15. So if you're monitoring troughs, drawing a level right before the next dose, we know that levels greater than 15 have an increased propensity for what we call VIN or vancomycin-induced nephrotoxicity. So we actually did a study with vitamin C orally to mitigate this. It wasn't statistically significant, but we did see a clinical relevance, meaning more studies need to be done to prove or disprove it. So test of concept, if you will. But again, very large structures. So the oral formula of vancomycin is poorly absorbed. Just assume that it's not absorbed at all. So we use it topically for Clostridium difficile infections. And of course, it's all excreted through your kidney, 100% for the most part, dependent on your GFR. Renal dose adjustments are required, and we're drawing levels. So you do want to make sure you use it with caution with other nephrotoxic drugs. Another study came out using what we call vancomycin. It's a combination of vancomycin and zosyn. Remember, zosyn being a broad-spectrum anti-pseudomonal penicillin antibiotic. It's a combination of piperacillin, tazobactam. We do see more VIN with that, and other studies just came out that supports that. But just keep in mind, zosyn in and of itself, though, can just decrease excretion of serum creatinine, which is going to give you an elevation, but it's not of your serum creatinine, but it's not indicative of underlying nephrotoxicity. But it's not enough. Zosyn, when you give this with zosyn, you do increase your risk of nephrotoxicity, with the vancomycin being an oxidative process, the zosyn being an interstitial process. When we have vancomycin, some pearls, when you treat it, if you have an MIC of 2 for Staph aureus, the best thing is don't try to outdose it. Just change products. Just change to daptomycin or change to something other. We have multiple drugs now that cover MRSA that can be used. So if it's 2 or higher, don't worry about it. Just change to another drug. But remember, with automated systems, you go from 1 to 2. So if there's any little growth in here and the light's refracted, it's going to call the MIC of 2. I may take this, which I have, and I may plate this, which I've done, and I do. I may plate this, and I put an E-test strip on it, just what I showed you earlier with the Abicaz, and it's actually 1.25. Remember, these are log 2 dilutions in an automated system. When you do an E-test where you plate your own McFarland concentration and you put down your E-test for vancomycin, that's incremental. You may find out that it's only 1.25 or 1.125 or 1.25. It's not a 2. So you're not getting therapeutic failure, and it's working fine. So if you can't reach the target, don't do it with aggressive dosing. And for ribavancin and dalbavancin, that's once weekly. Both of these are actually one and done for skin and skin structure infections. Ribavancin is going to be 12 milligrams per kilogram times, it's going to be 1,200 milligrams, just 1,200 milligrams times 1 dose. The dalbavancin is 1,500 milligrams 1 dose. They're very, very expensive, in the thousands. If you're curious how we deploy these in endocarditis and osteos where we need more, I can tell you, and was part of a big study, not a cadre, but I mean a national study, 1,500 milligrams of dalbavancin on day 1 and then repeated on day 7, and that's it. They're seeing benefits to that. It hangs around for a very, very long time. But again, these are going to be very expensive drugs, and you're going to have to get prior approval from not only the insurance, but your hospital system as well. But there are places for it. It's not everywhere, but there are some situations where you would want to consider that. But for the most part, we have other options. I like doing 7 to 14 days of I don't use the word step down, but going from vanco to oral and nasal, even for infective endocarditis. We certainly used it in Cajado. When we went to the hospital, they were using it for 12 months on multi-drug resistant tuberculosis, and they were just doing eye checks. They really weren't having issues with thrombocytopenia. So some neuropathies, yes, but they would do their eye checks. That's the biggest concern is optic neuritis because it can lead to blindness. Get some pulse steroids for it, but it can lead to blindness, and they're reversible. But they do ophthalmological exams, and they mitigate that, or prevent it. Not mitigate, they prevent it. Not just, hey, you're having some trouble, we need to stop. We need tap the brakes. But here you go. Where do we use them? We can use ampicillin for enterococcal faecalis. We have better choices for strep pneumo, same with strep pyogenes. We use these for MRSA. That's what we're targeting. End of story. The glycopeptides. And remember, your prototypical drug is going to be vancomycin. So unique to vancomycin, we used to call this red man syndrome. That's no longer politically correct. They refer to it now. And I just haven't changed this. I'm not meaning to be offensive if I am. That's just what we called it for years. It's referred to now as vancomycin infusion syndrome. This is not an allergic reaction. You just stop the current infusion. If you want to give some antihistamines, you can, but all you need to do is restart it at half the rate. But we give vancomycin at no more than 1,000 milligrams per hour. So you can see here, though, the redness in the chest and on the leg. Not so maculopapular type rash. Looks good. I mean, that's what you see. And then up there on the chest, it's been called redneck syndrome before, but just something to keep in mind and something you need to be aware of. But it's going to be referred to as vancomycin infusion syndrome. Okay, so keep that in mind. And that's how you take care of it. The nephrotoxicity is not going to occur with one dose. It's usually going to be serum creatinine. You want to check it every 3 to 4 days. If you start seeing some nephrotoxicity, it's going to typically be 72 hours and beyond. You can have ototoxicity. This is going to be related more towards the peak. So we don't measure peaks anymore. We get to levels sometimes within an interval, but that's just because that's how we calculate the area under the curve if you're dosing it that way. But usually it's with other ototoxic agents. I'm hoping you're thinking the common one that's ototoxic, aminoglycosides, but also loop diuretics. Hematological suppression, you can get some leukopenia issues with that. You can get some thrombocytopenia with that. So it's not common, but it's possible. But the big thing is going to be nephrotoxicity. The higher your trough, the increased risk you are of nephrotoxicity. The peak is correlated more with ototoxicities. So how do we dose it? A loading dose, usually all patients, give them 20 to 30 milligrams per kilogram. We use actual body weight, but we do cap it at the most part. Don't exceed 2,000 milligrams. Some institutions will say don't exceed 2,500 milligrams. What you do if their kidneys are in order and it's a big person and you think it's going to be a Q12-hour interval, we'll give them their bolus dose, their loading dose of 2 grams. And then instead of waiting 12 hours for the next dose, maybe start the Q12-hour regimen 8 hours from there. But the indications, we use it for all types of endocarditis, both left and right-sided endocarditis. Your right side is more likely to be an IV drug user. No doubt for meningitis. For meningitis, we're probably giving a 30 milligram load. For endocarditis, you can really target, based on what we know now, troughs of 10 to 20. That's when we do AUC dosing. For meningitis, I would go ahead if you're doing trough dosing. I'm going to say go ahead. That says VT, vanco trough. I would keep it around 20. The osteos, it just depends on perfusion of the patient, but that's going to be, again, between 15 and 20. is what you're going to want. Endocarditis will be 15 to 20. If you do AUC dosing, what you're going to find is lower troughs correlate with AUC. So I'm not a fan of this trough dosing. You have to draw the levels. It correlates, no doubt there's correlation to a trough, but it's not as aggressive. Pneumonias, the old guidelines are 15 to 20. Febrile neutropenia, 15 to 20. Sepsis or septic shock, if you know the focus, it's going to be whatever the focus is. If you don't know what it is, initially it's 15 to 20. If you have neck fash or skin structure, that's 10 to 15. That's the old dosing. No, though, more and more places are going to the AUC dosing. And when you do that, you're targeting an AUC. Yes, we have fancy calculators. I know the formulas to do it by hand, but I use a program. But we want 400 to 600. And we did an internal study at a previous hospital I worked out, and this correlated 400 to 500 correlated between 12 and 14. So if you wanted to get up around 600, you're going to start getting up around 15 or higher, but I would target 400 to 500. And once I established that, if the trough that correlated with an AUC of 450, regardless of renal function, if the trough was 12.5, I'd try to get it around 12.5. And I know based on literature, that decreases my risk of vancomycin-induced nephrotoxicity. Okay. Now, your usual dose frequency, typically it's going to be 15 milligrams per kilogram per dose is a good way to go. Most will be every 12 hours. So depends in the pediatric. Most of those are going to be Q6 hours. Young adults, adolescents, Q8 hours. Good renal function. Creatinine clearance greater than 100. You're going to need Q8. But as the renal function diminishes, you're going to have different changes. Now, what I want you to do is after you're done with this lecture, I want you to take time to Google vancomycin dosing protocol and just or Google Stanford. I use theirs, or Northwestern. I have mine. I'd show them to you. But just Google vancomycin dosing protocols and just look, read what the protocols have. I'm not going to test you on anything you read out of those protocols, but I want you to have an appreciation on how it's dosed. So, but again, we usually get our trough concentration at steady state. So as you all know from the first semester of pharmacology, we're looking around the 4th or 5th dose. And we're going to monitor the serum creatinine and urine output. A lot of times, decreased urine output is your first sign of impending renal failure because your serum creatinine increases are going to be 24 to 36 hours behind. So if a patient has zero urine output, what's their creatinine clearance? Regardless of what their serum creatinine is, you got it, it's zero. So make that easy for everybody. Okay, indications, we talked about that, but these are these trough concentrations. If you're doing trough dosing, bacteremias, endocarditis, osteos, meningitis, pneumonia, neck fash, not necessarily, you don't have to get aggressive. Sepsis or septic shock, if you're not sure what the cause is for that, we're gonna target 10 to 20 milligrams per liter. A lot of places will mark that as micrograms per milliliter, so keep that in mind. And then if it's a urinary tract or skin cellulitis, 10 to 15 micrograms per mil. But remember, I'm a big fan of AUC dosing. So I go by hospital protocol, wherever that is, whatever that may be. But in a lot of cases, if the patient's getting better, staphylococcal infections outside of skin structure, abscesses, are not overly common. They're not uncommon. But I try to find an opportunity to get the vancomycin just completely de-seed by hour 72 if there's not a compelling indication to continue it or a definite culture intensity that says, hey, this is MRSA. If it's MSSA, I'm going for cefazolin 2 grams Q8. I don't care about the inoculum. I've read the studies. I get it. It's not the inoculum effect. It's an in vitro phenomenon, not an in vivo phenomenon, but hopefully source control was obtained regardless. So, but you want to always make sure the patient received all their doses, and the timing is always important. Timing is always off. Was the trough drawn after the first dose or the 5th dose? That's very important because is it at steady state? Your first trough, if it's 15 already, by the time you get to the 4th dose, it's probably going to be 25 or 30. So that's very important. Don't get it with the first. Get it with if it's Q24 hours, get it with the 3rd or 4th. If it's Q8 hours, get it with the 3rd or 4th or the 5th, but is the patient getting better? If they're getting better, don't get crazy aggressive. Don't treat a number. Don't treat a number. treat the patient, please. Please, 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 please. And dosing adjustments, make those linear kinetics. That makes it if you can cut doses in half, or if you need here it is down there. This is what I actually teach my pharmacy students and residents as well. You can have fancy formulas, but if your trough is low, dose more frequently, proportionally going to increase. If your trough is high, dose less frequently. So if your trough's too high, go from Q12 to Q24 to Q36, whatever. If your trough's too low and it's a steady state, go from Q24 to Q12 or Q18, whatever it may be, do that. But if your renal function is stable and you're close to target concentration, just make proportional increases and decreases. You don't have to make insane. If your target is 15 to 20 and your level's 14.9, come on, give me a break. I could manipulate this by changing the infusion from 1 hour to 2 hours, or vice versa. And I can change this whole thing. I know how to manipulate pharmacodynamics with linezolid. I can turn it from a bacterial static to a bactericidal in pneumococcus just by extending the infusion to 3 hours. So just keep that in mind. You can manipulate pharmacokinetics, and not necessarily kinetics you can't manipulate, but you can manipulate, well, you can get probenecid with penicillins, that's manipulating kinetics, but dynamics, we can manipulate that even by changing the length of the infusion, whether it's continuous, intermittent, or extended. So phosphomycin, a drug that I'm a fan of, not overly using it a lot, but it comes in a sachet. The IV's not available in the US yet, but if you just have a simple cystitis, meaning not a pyelonephritis, it can be a complicated UTI without pyelonephritis. That's a different dosing scale and phenomenon. I don't think we can meet our targets with the oral sachets. I think the oral sachets, it's a packet, are 3 grams. It's good, though, if you've treated someone with a couple of doses of levofloxacin, give them a dose of phospho to finish it up if you don't want to send them home on prescription. There's a lot of ways for this to work, but the brand name is Monuril, and it's oral. It's spectrum. It covers enterococcus. But you also get some Staphylococcus saprophyticus. If you're not familiar with this, with females, a lot of times after sexual activity, intercourse, they have UTIs, and many times it is saprophyticus. And you take preventative medicine, phosphomycin, maybe in that place. It does cover ESBL, so it gives you an option in Pseudomonas. If you're doing 5 days of therapy and you've done 3 and you want to send them home, you can give them a one-time dose of phosphomycin. Now, I will say, if you're going to do that with an ESBL, I'm going to recommend that you give 3 grams times 2 or 3 doses, divided 48 hours apart. If it's something simple like enterococcus or multi-drug, maybe just 1, but it depends. But it's a good way if you want to do 5 days of therapy total and you're on day 2 or 3 and you're going to send them home from the hospital, it's a good option to give 1 more dose of this before they go home, instead of keeping them around just to get antibiotics, just to get 5 days of therapy. So keep it in mind. I'm not sure about the costs in the hospital. That's not really relevant, but if it's in the outpatient setting, there's a chance it could be expensive. But how it works, you have a peruvial transferase, and that's where phosphomycin comes into place. In essence, we're inhibiting that transferase, and that's, again, involved in the first step when we look at formation of the cell wall, peptidoglycan formation, right? So there's your mechanism, block cell wall formation by inhibition of the UDP in acetylglucosamine anol pyruvyl transferase. And there it is right there. And you're blocking the N-acetylglucosamine to N-acetylglucosamine pyruvate and pyruvyl transferase. So just keep in mind that's what we are doing. And it's a good drug. It's bactericidal. A good distribution to the kidneys, bladder, and prostate. There are ongoing studies for prostatitis. I think there may actually be a dosing schematic in there. There tends to be higher failure rates from what I've read. I haven't scoured the literature for phospho, but no doubt when you have cystitis, it's a good option. Before you deploy this for an actual pyelonephritis or prostatitis, look at the drug books for the dosing and appreciate it, and look at the literature and see what the new guidelines are. I don't know if you can get the high enough doses orally, PO. It is IV in other countries, but I don't think it's here in the US yet. Matter of fact, I know it's not. So, but there's no renal hepatic dose adjustment, so that makes it nice. There's no significant drug interaction. So It makes it a very clean drug, especially if you just need a couple of more days of therapy for that UTI only. Give them a dose in the hospital and send them home. So, but the clinical pearls, you get very high concentrations in the urine for several days, hence the one and done, the one-time dose for uncomplicated UTIs. But just appreciate if you have ESBLs, you may want to give a second dose in 24 hours. You need to appreciate that. So here you go. There you go right there. Dosing, yeah, right there. Prostatitis. See, 3 grams every 3 days for 21 days. So it's very important that you follow that. Prostatitis we treat longer. But UTI in women, you can give 3 grams for 1 dose. All UTI in men are considered complicated. And there you go right there. It's 3 grams every 2 to 3 days for 3 doses. So this is what I was preaching about. So you don't have to look it up now. Would I use it for pyelonephritis? I probably should be able to quote literature for it like I do on a lot of things. This is one I need to look up myself. It seems like the last time I scoured the literature, things pop in my mind. And after we're done with this lecture, I'm certainly going to do it because I try to keep my database in my mind up to date. But I need to do I'll do a PubMed search, phosphomycin, throw some mesh terms, whatever. But phosphomycin, pyelonephritis, those are going to be my 2 main words or hit pieces on it. And we'll go from there. But there's your prostatitis dosing, and I think this just sets yourself up for missing a dose. Is it day 3 or day 2? So, but up to you. Lipopeptides, another good group of drug, daptomycin. Big fan of daptomycin, but let's talk about it. Brand name is Cubicin. I've done a lot of work in the research area with the daptomycin, with the actual company that developed it. It just went blank on Cubist, C-U-B-I-S-T. That was the initial company. So anyway, daptomycin, again, this is a great alternative because it covers methicillin-resistant Staph aureus. And it covers Enterococcus, including vancomycin-resistant Enterococcus. But it's very important. We've actually had an actual patient we did a case study on where we induced VRE, I'm sorry, it was VRE, but we induced daptomycin-resistant Enterococcus by doing lower doses. So I think it's very important that we talk about the dose. Now, one big thing about daptomycin, can you use it for pneumonia? The answer is no. Is it because it doesn't get in the lung? No, it does, but it's bound by surfactant. So there's no active drug to kill your staph or your strep or whatever it may be. So that's one thing that you cannot use it for is pneumonia. Now, if it's an empyema or something like that, and there's nothing else, you could probably get away with it, a true lung infection. But if it's actually an alveolar, a pneumonia, you can't do it because it's going to be bound up by surfactant. So keep that in mind, okay? No pneumonia. And I have it right there. We use it for severe and resistant gram-positive infections except for pneumonia. And those infections are going to be MRSA and VRE. Those are the big ones. Those are the big ones. So you can see its mechanism. So it binds the cell membrane of those gram-positive bacterium. It's a calcium-dependent process. So channel forms in the cell membrane. You get outflows of potassium from the cell, which leads to a disruption in the cell and a subsequent death of the or a disruption in the integrity of the cell wall. So there it is right there. Dapto, right? Calcium, your step 1, binding and insertion, oligomerization and channel formation, depolarization and ion influx, and then there's your disruption. So that's how it works. Very nice drug. It's IV only. I like it. You can see the coverage. Yes, we use it for Enterococcus faecium. That's usually faecium is typically it's coded for what we call a VAN-A gene, which lends it resistant to vancomycin. Enterococcus faecalis, we typically can just use ampicillin. So I'm not really going there. Pneumococcus, we have vancomycin. We have multiple other, if it's multi-drug resistant, ceftaroline. So we usually don't go there. It covers them, but we're not using for these. So you can see where we're using it. And again, MRSA. We wouldn't use it. We would use cefazolin here. It covers all this, yes. But where do we clinically deploy this drug? You see where it is. It's VRE. But just know, if you're doing VRE, I would not give a dose less than 10 milligrams per kilogram. If it's someone who's really big, maybe go with 8. But I'm telling you right now, and you can scour the literature and fact check me, but if you do 6 mg per kg, something along those lines, maybe even 8, you're going to set yourself up for potentially a therapeutic failure. Your patient gets better. Let's say it's VRE and a bone. ESRs and CRPs are going down, and then you go through 6 weeks of therapy, you DC it, and they come back and they tell you the vertebral column. If it's a vertebral osteo, they have pain again, and you see the osteo's back, and you end up with a chronic osteomyelitis. So you got to appreciate the length of therapy and the dose when it comes to VRE. MRSA, I think 6 to 8, depending on where it is appropriate. But when we talk about VRE, if you ask me, and people argue with me and tell me I'm wrong, but I'm going to say 10 mg per kg. I've read the literature, I've seen the inducement, and I think it's a dosing phenomenon. Some will cap the dose. I don't cap it. I think when it comes to MRSA, I think capping doses at 750 to 1,000 are not necessarily not wrong. But when it comes to VRE, I'm not capping, but I'm going to monitor the patient. It can lead to some muscle breakdown. So we're going to monitor their creatinine kinase every week. And if it gets up to 5 times the upper limit of normal and their muscles are hurting, I stop it. If it's 10 times the upper limit, with symptoms or not, their creatinine kinase, we just stop the dapto. But VRE, you have to be very aggressive. You can induce the resistance. And I've actually seen it on an actual patient who had vertebral osteo. Witnessed it myself. So renally excreted, so there is a renal dose adjustment if the creatinine clearance is less than 30. What it is, the adjustment is less than 30, is that you go to Q48. No major drug interactions, so that's good. But although when you give it with statins can have some myalgias, etc. It can be potentially exacerbate that. But clinical pearls, it's not efficacious for pneumonia because it's inactivated by lung surfactant. You need to know that. It can be administered as a 2-minute IV push, so that makes it somewhat attractive in a doctor's office or infusion center. Although in an infusion center, if you're going to get an infusion fee, it has to be over 15 minutes, so that could maybe be a money loser for an institution. And might be a reason. How come if you went to an infusion center and you were to ask, how come we don't give the daptomycin IV push? And it's because the answer is going to be because we get an infusion fee if we do it over 15 minutes. But in an ED, a busy ED, you could dilute a vial and give it if you needed to. So it may cause eosinophilic pneumonia. I patient one time with an ID doc here, no longer in Abilene, but we actually thought we had a patient that had eosinophilic pneumonia. It depends on what you read. It's very, very rare. Does it cause it or not? Correlation, causation. I'm going to say correlation. Anyway, how do we treat the patient? Eosinophils, they are your friend. They are your immune system, but they're extremely destructive. We talk about DRESS, that eosinophilic signs, systemic signs and symptoms due to eosinophils and a DRESS reaction. And you can get a lot of damage to tissue and lungs. How do we treat it? In this case, we stopped the daptomycin. We gave steroids. But very rare, regardless. If it does occur, it's not going to be on day 1. It's usually 2 to 4 weeks after therapy. They've done other studies on it. Again, we think we saw a case of that because the patient's pneumonia. We weren't using it for pneumonia because remember, daptos, we were using it for skin structure infection or an osteo is what it was. I can't remember. It's long term. So it had to be an osteo. And the patient started having what looked like pneumonia, and they went in and did a bronchoalveolar lavage and eosinophilic pneumonia. We reported it, but very, very rare. Something else associated with reversible myopathies and rhabdomyolysis, very rare. It's going to be more of a dose phenomenon, but we will draw a baseline creatinine phosphokinase or CK at baseline and then every week if it's long. We use this daptose typically because it's once daily. It's a beautiful drug for outpatient antibiotic therapy for OPAT. But how do we monitor that? Well, if your CPK is 10 times the upper limit of normal, or 2,000, we will DC it. We will stop it. If your CPK, regardless of symptoms of muscle pain, if your CPK increases to 5 times the upper limit of normal with signs and symptoms of myopathy, we will DC it. So we're monitoring for signs and symptoms of myopathy. We're checking a number to see if it correlates with myopathies, but you certainly want to consider discontinuation of daptomycin or statins if potentially, depends. We give statins with dapto all the time. Some will want to stop the statin due to the potential increased risk of a rhabdomyolytic process. But before you stop someone's statin, I'd talk to the cardiologist first, because there's various reasons they're on that for other things, whether it's stroke or coronary artery, whatever it may be. But just something to keep in mind. I could see that being a test question. Which drug would you consider discontinuing if a patient's going to be on long-term daptomycin to decrease the risk of rhabdomyolysis? You're going to be looking for that statin drug, such as rosuvastatin or atorvastatin, which in my opinion are the only two that should be used. Okay, polymyxin B and colistin. Guess what? Because of Avicaz, which is ceftazidime avibactam, because of Webermir, meropenem vaborbactam, because of Carbrio, the imipenem relebactam, guess what? We've pushed these to the back counter, but before those came out, colistin, which is polymyxin E, and polymyxin B are all we had. And here's the problem. The therapeutic index, the toxic dose, guess what? Equals the therapeutic dose. You were pretty much guaranteed acute kidney injury. And most of those patients were pretty much in line for hemodialysis support or RRT, renal replacement therapy. So no good. But the good news is those options, this is what they replaced your colistin and your polymyxin B. I'm not going to go into the big difference. I'm a fan of B. I'm not going to go into the reason why, but you can see the colimycin IV IM inhalation. This is a prodrug that does come into the conversation, because if your renal function's intact, you excrete the drug too fast and it's never converted to the active drug. So you don't actually get a pharmacological benefit, but you do see some colistin inhalation in some patients. It just depends on the situation. Polymyxin B, we do have IV. We will use it some. It has less nephrotoxicity. It's still there, but you see it more often sometimes with ophthalmic and ear drops, and then topically as well. But the spectrum, you're for the most part, you're going after gram negatives. With these drugs, they're going to be gram negative only. And you can see there, gram negative organisms only, and specifically Pseudomonas, Acinetobacter. You do get your CREs and your KPCs, but no coverage for your gram positives. So forget Staph aureus, forget Enterococcus. Atypicals aren't cell wall, and you're not going to get anaerobes. So these are going to be last line therapy for multi-drug resistant pathogens. That's where we use these. But remember, I have used these before. I have quite a bit of experience with them, doing the dosing, doing the monitoring. But guess what? Haven't done it in years. Why? We have Avicaz, we have Webermir, which is my favorite, and we have Ricarbio, which is another good-looking drug. We have those options now. We don't have to use polymyxins. How do they work? The polymyxins, they're charged. It's a positive charge, and that allows them to bind to a negative, right? Positive, negative, of the lipopolysaccharide layer of the gram-negative organisms, right? What does that do? That leads to disruption of what? Cell membrane, cell wall. What does that lead to? Lysis. What does lysis equal to? Disruption, whatever, death. And that's how they work. And again, they're bactericidal. You know how to pick out the ones that are static. Remember country music television, your clindamycin, your macrolides, which is going to include your azolides as well, such as Ketec, or your Biaxin, your clarithromycin, your Z-Pak, your azithromycin, and then your tetracyclines like doxycycline or minocycline or tetracycline, tigecycline or ribocycline, evacycline. The list goes on and on and on. But you can see here that the lipopolysaccharide membrane, the disruption, boom, you kill it. I'm so glad we don't have to use these drugs anymore. And there they are. Your big players where you would see this, KPCs right here. You don't really see much E. coli, multi-drug resistant Pseudomonas. And I said Acinetobacter. I don't know about that. Gosh, when you have crab, which is carbapenem resistant Acinetobacter, is there really anything good for it? Cifidorocol came out. That was the Trojanta, the Trojan horse, but that had an increased signal of death. And when they did subgroup analysis, they found out that the group that was dying was the group that had Acinetobacter. So I don't know what to think about that. But your Kinetics, they are renally excreted. Renal dose adjustments are required. Certainly other nephrotoxins given with it can potentiate it, but your clinical pearls, the nephrotoxin and neurotoxicity concerns has limited the parenteral use of these therapies. Last line therapies, now there's really not a reason for polymyxins. If your Abicaz or your Vabamere or your Carbapenems aren't working, I don't see how polymyxins are really going to add anything to it. Now, when you look at the recommendations, if you were to see my Bad Bugs New Drugs, when you do have extremely drug-resistant pathogens, meaning everything's resistant, this does become part of the combination. So just something to keep in mind. So, but that ends the discussion of cell wall antibiotics. So let's take a quick look at that. There's that right there. That's a great picture, by the way. Great picture. But let's see where we're at. Let's go to our home. We're going to keep, we still have some time before we're done with these lectures. So remember, we're week 2, lecture 1. And what did we do? We were, all these study sheets, you need to go over these. And they will correspond as you go down the list to what we're talking about, okay? So please, please, please do that. There's part 1, there's beta-lactam cheat sheets, part 3, cell wall. There's your glycopeptide cheat sheet. Okay, protein synthesis. So this is where we are now, our protein synthesis antibiotics. And these are going to be your what I call your clean tags, your clendolinazolid, your macrolides, your tetracyclines, and your aminoglycosides. That's what we're going with right now with these. So we'll jump into it and just keep on moving on, and we'll pick up where we left off. Okay, so we're leaving the cell wall, and we're jumping into the protein synthesis inhibitors. You all can appreciate what our objectives are. And these are not, well, let's say they used, I know the beta-lactams, they're your best, they're the most efficacious group of antibiotics in my opinion. But anyway, we talked about cell wall synthesis. We talked about the beta-lactams, which are the penicillin, cephalosporins, the carbapenems, and the monobactams. We talked about vancomycin. We appreciated polymyxins, right? We talked about those. Well, now we're going to talk about those 50S and 30S subunits. Now, I'm going to give you a little way to remember this. If you look at this, it kind of looks like home plate, doesn't it? Right? In a baseball game. So one thing, clean tag. So the 50S and the 30S, the big part of the plate has the bigger number. The lower part has the lower number. And think of clean tag, clean, clindamycin, L, linazolid, phenol for the C, E, erythromycin, or the macrolides. Keep that in mind. And then clean tag down here, the 30S tag, tetracyclines, and AG, aminoglycosides. That's one way you can remember. If I ask you inhibition of a 50S ribosomal, you just look, you have the answer now. I just told you. So, oh, there it is right there. So clean 50S tag. Remember this picture. Remember clindamycin, linazolid. The E stands for erythromycin, but just think of all the macrolides, which would include erythromycin, clarithromycin, and azithromycin, the world-class Z-Pack. And then the tag, the smaller part of the plate, the smaller number, the 30S, tetracycline and aminoglycosides. So anyway, bacterial ribosomes. So 70S consists of the 30S and the 50S. I'm not going to go on the explanation. Why does that equal 70 when it should equal 80? But what are these? What do they do? They're responsible for carrying out the protein synthesis of the bacteria, which in essence is a conversion of messenger RNA into an amino acid peptide chain. So there you go. That's how they work. If the bacteria can't make its proteins to produce a cell wall, they can't grow, and thus what? They will die. Now, as you know, a lot of times these are considered static. I told you my opinion on cidal versus static. I don't really differentiate them. But again, you have your clindamycin, linazolid, your macrolides, your tetracyclines, your statics. So when we start talking about bacterial protein synthesis, a lot of times we're appreciating a static mechanism. And remember, when I say static, all that means is over 24 hours, it did not have a log 3 kill. Even if this is hour 24, even if it missed it by just that much, it's going to be called static. So remember that. Don't let it fool you. This is a case where I would take it then Instead of giving it over an hour, I'd give it over 3 hours and I'd manipulate it and I'd make something cidal. But anyway, very important. Understand the mechanisms right here. If you know this, you got the test question right. Okay, actions at the 30S subunit. This is the tag. So these are going to be your tetracyclines for sure, and aminoglycans and the glycocyclines. These are tetracyclines. So these are higher glycyl cyclines are higher generation tetracyclines. For simplicity, I like to throw them in together. So this is going to be like tigecycline or ribocycline, etc. Your aminoglycosides, your big ones, are going to be your gentamicin, your tobramycin, and your amikacin. There's another one called plazomicin that is similar in terms of being an aminoglycoside. So let's start with the tetracyclines. So here you go. Doxycycline, which I like. You can even give this to younger youth, even with teeth being grown, if it's, just 3, 4, 5 days. Minocycline, right? The drug of choice for stenotrophomonas is Bactrim sulfamethoxazole trimethoprim. But just remember, minnow is a great option when you have resistance. I say minnow for steno. And then tetracycline, which we don't use. A nice little pearl about tetracycline. This is one when they say don't use expired antibiotics. This can actually lead to what they call Fanconi syndrome. If you don't know what that is, you need to look it up. Because you see it with chemotherapy sometimes. But you'll have a lot of electrolyte disturbances and things like that. You're dumping stuff. But those other generation glycocyclines, there's the tigecycline, which for some reason I don't have that on here. But a ribocycline and a metacycline give you some more options. Now, in general, though, when you talk about tetracyclines, and they cover a lot, but I don't know if you all are familiar with MP3 players, but what they don't cover is Morganella. They don't cover Pseudomonas, the 3, so there's the M, but they don't cover P times 3, so Providencia, Proteus, and Pseudomonas, they don't cover. So that's one way to remember, but it does have activity against vancomycin-resistant enterococcus. It does have activity against MRSA. It does have some anaerobic coverage as well, and it covers atypical. So it's not a bad antibiotic. I can tell you this, when you look at the antibiotics that cause the most dysbiosis or disruption of your normal flora in your large intestine, I can tell you right now that these are the least likely to create that. And their association or correlation or causation of someone colonized with C. diff is a lot lower. So something to think about. I'm a big fan of doxycycline because it covers, especially for skin structures, to send someone home, because it covers Streptococcus pyogenes quite well and MRSA. So you have your options, but and there's your spirochetes. But yeah, no Pseudomonas coverage, nor Providencia or Proteus, specifically Proteus vulgaris. But what do we use? We use it for acne. We've seen it there, cutiform bacterium, skin and soft tissue infections, respiratory tract infections, only more along the lines of CAP with doxy, because you get atypical and you do get some pneumococcal coverage. In the hospital, we don't do that. We tried that with a drug called Tigasil, the brand name's Tigacycline, and we got a negative ping, if you will. We had increased mortality, and that may be why. It may be due to the fact that it doesn't cover some of your more prominent nosocomial pathogens that cause nosocomial pneumonia, specifically your HAPs and your VAPs. So just something to keep in mind. But there was no doubt a negative signal. STDs, your chlamydia, and your syphilis, right? Lyme disease, doxycycline, if you've had a tick bite, I don't know what the actual rules or the regs are, but I think if you've had a tick latched on for more than a certain amount of time, you need to get some prophylactic or empiric doxy, because you certainly don't want to get Lyme disease, Rocky Mountain spotted fever, and then leprosy, minocycline. So you can see it kind of has some of that oddball reason to use them out there. But what do they cover? There's your doxy, again, mainly for a gram negative perspective. We're not really getting into the gram negatives with this, but I think doxy is a great option. You can give it IV, you can give it oral, so it's an opportunity. It's not a bad drug. The mechanisms, though, we're talking about, remember, tetracyclines. We're talking about that 30, that binding to that 30S subunit. And that's on the bacteria ribosome. We are affecting MRSA etc. But there you can see enters the bacterial cell through passive diffusion or energy-dependent transport, binds reversibly to the 30S subunit of the bacterial ribosome, prevents transfer RNA from binding to messenger RNA in that ribosomal complex. You know what RNA does? You just interfered with protein synthesis. Compromise the integrity of the cell wall, and you're done. And there's that 30S ribosomal subunit working right there. Now remember, your Clinda and your nasalid, your streptomycin, chloramphenicol, they're going to be working more up here. Azithromycin, erythromycin, etc. Excellent absorption. That's what makes them so nice, is it makes the PO option a real option, especially in long-term antibiotic therapy. You don't necessarily have to give IV antibiotics when you have 100% bioavailability. Ask yourself the question, could we use this? We typically administer these at least 1 hour before or 4 hours after dairy products. That's because divalent and trivalent cations can bind it. So co-administration can decrease the absorption of the antibiotics, especially tetracycline. Not so much with the others. With doxy and some of the others, that's not that big of a deal. But tetracycline, if anyone uses tetracycline, other than H. pylori with high resistance in the 4-drug combo, I don't know where it does. It does distribute across the placental barrier and concentrates in fetal bones and dentition. Your metabolism, excreted through bile, so no hepatic or renal dose adjustments. And you can read through the rest of these, but no major drug interaction. So overall, not a bad class of drugs. We just don't see it used often or a lot. So keep that in mind. Clinical pearls. GI disturbances are very common. So we administer these with fluids or food. The exception is tetracycline because that can decrease the absorption. Doxy, a lot of people will complain about puking after their doxy. I've never had problems with it. There's one called tigecycline IV that we give in the hospital. That you were pretty much guaranteed to get nauseated with that. That was actually a drug. The intent, it's 100 milligrams times 1 as a loading dose, and then 50 milligrams twice daily. It has a very long half-life. The initial plan was to have a once daily antibiotic at 100 milligrams daily, but the reason patients were getting super sick, so they said, well, let's break it up into 50 milligrams twice daily, and that decreased the incidence of nausea and vomiting, and so they went with that. We typically don't use it in pregnant or breastfeeding women due to the incorporation into bones and dentition. Doxy you can get away with for short-term use in the younger population, but you can get discoloration of teeth and some stunning of growth. Phototoxicity is real, so you need to wear long sleeves or adequate sun protection, no doubt. The tick-borne diseases we talked about, if we're talking about Rocky Mountain spotted fever and rickettsia or Brucella and Lyme disease, we use it for that. Again, if you've been out and about and you find a tick on you and you pull it out and you don't get the head of it or it's been latched on for a while, I would be trying to get yourself some doxycycline. There's a protocol for prevention. Emergency use from a terroristic perspective, anthrax, tularemia, bubonic plague, not brucellosis. I saw a couple of brucellosis cases. We couldn't rule it out, but it looked just like it on a couple of the herders' hands. They herd a lot of animals, cattle and sheep and goats in Africa, and I saw several of them. And guess what? We had a lot of doxycycline, so I was switching some of the antibiotics over to doxy because I knew it would cover if there was a staph instead of trying to cover staph, but why not give doxy and cover both of them? So it's pretty interesting. Though, look up brucellosis and see it's if you work in a rural community, it's not uncommon to see that. It's not just if you watch Yellowstone and Dutton or Dillon, whatever that guy's name is, that was worried about buffalo bringing brucellosis to his cows in Yellowstone, whatever. Humans can get it too. So look it up. Look at the little wounds you see. You see it in the U.S. not often. I think we gave a guy some streptograms one time for it. I can't remember what. Weird deal. But you'll see it. But very rare, but good to know. There is an association due to intracranial hypertension with some pseudotumor cerebri. That's an interesting deal. If you don't know what that is, look it up. You'll have patients that have that. can lead to some vertigo type, especially with minocycline, some of your head spinning, ears are ringing type situation. And then the blue-black hyperpigmentation, you typically see this with minocycline. And I think I saw this actually for the first time a few weeks ago, but it's actually a blue-black. To me, it looked more like grayish hyperpigmentation of the skin. And this patient is specifically on the cheeks. I believe it's binding to maybe iron or something that oxidizes in the skin and gives it that blackish, bluish color. Fact check me on that. Saw it for the first time though just a few weeks ago. It's pretty interesting. It's legit. I don't think it hurts you. It's just part of it. You know, cortisone, amiodarone can turn your colors. But here's the glycocycline. So this is the Tigasil that I was picking on. Again, we got a pretty negative signal with this, with the increased mortality in pneumonias. I thought it was a good drug for skin structure. It's broad spectrum, no doubt. You're going to get the MRSA coverage. You're going to get multi-drug resistant streptococcal coverage. You're going to get VRE coverage. You're going to get ESBL coverage. You get Acinetobacter coverage, but you have others for that. And you get anaerobic and atypical coverage. But remember, you're not going to get Pseudomonas coverage. You're not going to get Proteus coverage. You're not going to get Morganella coverage. You're not going to get Providentia coverage. And maybe that's why they had an increased signal in death. Now, when they were using it in bacteremias, this has a very large volume of distribution. So you give the drug, it's in the blood, but distributes to the tissue very quickly and very highly. So there's not much left floating around in the blood. And so it's not going to be a very good choice for bacteremias. So really where we would use it is complicated skin structure infections and complicated intra-abdominal infections, because it would cover E. coli, including ESBLs, and it would cover Bacteroides. So it gave us a nice option to use. So, but there's your black box warning related to treatment. It's a higher mortality. So the thought was use when no other options are available. I haven't seen when tigecycline first came out, it seems like it was pretty popular, but you start getting black box warnings talking about mortality and increased death. That's one way for your drug to find a very quick death. So keep that in mind. The big thing though in the hospital is the amount of nausea it would cause. It was probably more than 50%, and up to 30% of them seems like they would puke. And it doesn't respond to Zofran. You would have to actually give promethazine, which introduces a whole other layer of potential issues in terms of giving an IV and the potential for vein irritations, and then no doubt the drowsiness that comes with that. So yeah, not a good deal. But again, tigecycline, Proteus mirabilis, yeah, but not vulgaris. But you can see here, very nice spectrum. But where I like it is VRE. I like the fact that it covers E. coli for the GI and Bacteroides. But yes, it does cover MRSA, which would be good for skin structure, but not in the blood because it has a high volume of distribution. And then when you get into the lung and we start talking about some of our ventilator-associated pneumonias or hospital-acquired, Pseudomonas becomes a player. Again, we saw the increase in mortalities. Only drug interaction, no renal dose adjustments to be worried about. Warfarin, no doubt. The tigecycline, you got to do it. You got to do it. Now, the clinical pearls, we talked about the side effects, the nausea and vomiting, up to 35%, especially with the 100 milligram dose. And there were some cases where we would give for KPC, some of the times we would actually do, especially Acinetobacter, instead of 50 milligrams twice daily, we would do 100 milligrams twice daily, Q12 hours. Patient was guaranteed to get nauseated, but possibly a high risk of puking. So that can cause its own problems. The normal dosing is 100 milligrams low, then 50 milligrams twice daily. The risk of hepatotoxicity, long-term use, you want to monitor liver functions. And then some of the concerns with tetracyclines, you can appreciate that and read it and know it. But the thing is I haven't seen this drug used in over 10 years now. So let's see where we're at. This may be a good place to stop. So 4:35, I'm not sure what time I started this discussion, but so this is, I'm going to make a note. We are week 2, lecture 1 of this week, and or lecture 4, 1 of this week, but 4 total. And we are going to start up next time with aminoglycosides. That's where we're going to start next time. So anyway, this is your first lecture for week 2. And we started with monobactams, and we've gone all the way to aminoglycosides. And we will start here. This will be week 2, lecture 2, when we start back up. So anyway, get out of here. Discard, stop share. I hope you learned something new. Thank you.